central theme really is courage, the courage to look at it, the courage to admit what's happening, to accept this is where we are. It doesn't mean you're accepting, oh, they're definitely going to die, but this is where we are. Like, you have this disease. This is what's happening with the treatment. The doctor said this. The courage to look at the dark parts if someone's feeling really sad or scared. The courage to say the word dying or death if that's what's happening. The courage to be present with somebody who's suffering and not to just turn away
Yeah.
and say, oh, I got to go. I'll go clean up the kitchen downstairs.
Yep.
If someone starts crying, just sit down next to them and hold their hand.
Hello, everyone. Welcome back to the channel, or welcome to the channel if you're new here. We have an incredible new author here with us today. We have Dr. Delia Chiaramonte, who is an integrative palliative physician. She has just written this much needed book. It's called Coping Courageously, and it is a heart-centered guide for navigating a loved one's illness without losing yourself. And when I heard that she was writing this, I thought, this book is so needed, as someone who in medical school thought, we do not learn how to hold space for people when we can't solve and cure what's going on with them, and also navigate those challenging discussions with families. So before we dive into that book, of course, Delia, thank you so much for coming to the channel.
Thank you so much for having me. I'm so excited to chat with you about this.
And for people who have not yet had the honor of meeting you, can you please share a little bit more about yourself?
Sure. As you said, I'm an integrative palliative medicine physician, which is a little bit of a made up specialty that I think needs to be a real specialty. So that's my personal mission. And I got here because I was first a family medicine doctor, then an integrative medicine doctor. And in that role, I was the associate director of a center for integrative medicine in a medical school. And then I'm board certified in palliative medicine also. And they were kind of parallel tracks for a while,
Yeah.
integrative medicine and palliative medicine. So integrative medicine, kind of mind, body, spirit, using all the tools, and palliative medicine is focusing on people with serious illness. And when I practiced both, I realized they really should be together. And so for a while, I was the division chief of integrative palliative medicine at a hospital, inpatient and outpatient, putting those two fields together, which I think is the most powerful way to address families who are facing serious illness. And so that's why I'm out here waving my flag.
I love it. And I had the fortune of being able to be in your integrative symptom management for physicians course. I'm a huge proponent of integrative medicine and palliative medicine, and not to be confused with hospice. Can you please share with the audience the difference between palliative medicine and hospice medicine?
Thank you so much for asking that question, because it's such a common misconception. So hospice is end of life care, generally the last 6 months or so of someone's life. Hospice is a tiny part of palliative medicine. So palliative medicine includes hospice, but so much more. Palliative medicine is the care of seriously ill patients and their families, focusing on reducing suffering. So the point is not to prolong life, but we're happy if people are prolonging their life. It's just that our focus is on reducing suffering, and that's physical suffering and emotional or spiritual suffering for people with serious illness. So that means if you have a cancer diagnosis, and your doctor is trying to either cure it or prolong your life by a lot, but you're anxious, or you have nausea or fatigue from chemo, or you have pain after surgery, all of those are appropriate for palliative medicine. So you may be trying to get cured, but you have a serious illness, cancer, and you have symptoms. So that means you're appropriate for palliative medicine.
And this, even for people in medicine, I find that a lot of feedback I get is that the consults are coming too late to palliative care. And oftentimes I think it's because even in our medical training, we equate hospice and palliative care, like, oh, they go together. But as you said, you can be actively going for a cure, and the palliation is of the symptoms that increase suffering.
Exactly. And honestly, physicians, nurses, NPs, PAs don't know this either. So it's not just the general public. It's really a misconception about the specialty that palliative care is the same as end of life care. So we would sometimes in the hospital in our consultation team go see a patient and one of the doctors on the team would say, "Oh, it's too early." Maybe somebody would have consulted us, but another doctor on the team would say, "Oh, it's too early for palliative." It's never too early. If you have a serious illness and you are suffering in some way, you have a symptom that's unresolved, it's never too early. So we help people with symptoms, with coping. So if you have cancer and you're in the hospital, you got some coping to do, right? Like it's not going great. And we help people with medical decisions, those three things. So if you have a serious illness and need help with symptoms, with coping, or with medical decisions, that's appropriate for a palliative care consult. So we are usually consulted way too late. That's
Yeah.
generally the idea.
And think about that decision-making tree. How are you going to make an optimal decision for you? Well, if you have support in coping and your symptoms are supported and managed, it's a lot
100%. Yeah.
more
And
clear.
we help people figure out what their goals are.
Mhm.
So a funny situation that not infrequently happens in palliative care consults in the hospital is the hospital team will consult palliative medicine for code status change, meaning they think that the patient should probably be DNR. And so they send us in to talk about that, make that happen. And sometimes we come out and we say, no, you know what? Their goals are to live every single day on earth possible that they can live. So they want to be full code, and that's perfectly appropriate because that matches their goals. And sometimes even we will increase the level of intensive care for a patient because that's what matches with their goals. So what we're there to do is to help them figure out the medical reality, like here's what's happening for you. Let's figure out what your goals are. And then together with those two pieces of information, we can help them make the right decision for them.
I love it. And as you and I talking, of course, I work at a cancer institution and have the opportunity to be doing literature reviews and meetings with the integrative medicine individuals. And what they bring in is such as acupuncture and yoga and all these different approaches that when you're in the hospital and you're feeling all that anxiety, to have something that you bring in to learn those coping skills, to learn the breathing, to have yoga, to have someone there for you. I find that to be so healing. And one of my missions is to bring the human back into the healthcare system. And of course, I always think, guys,
Yes,
you are like the poster child of doing that. So thank you for that.
absolutely. You're so right. And the thing that some people don't realize is that those modalities, so in palliative care, we use a lot of medicines and procedures. In integrative medicine, often a lot of complementary medicine, like you talked about, acupuncture, massage, etc., yoga. Bringing them together is really the ideal scenario because those techniques are not even just to, like help you relax. But for example, if you have unresolved anxiety or depression, your pain is harder to manage.
Yeah.
So we're treating pain also, right? We're not just giving them like a spot treatment. If you have anxious feelings physiologically in your body, sometimes that brings on nausea. So people can be nauseous partly because of chemo, partly because of other medicines, but partly because of anxiety. And so if we're going in there to manage your nausea, we may use medication, but we may also use deep breathing or yoga from the bed or acupuncture, et cetera, which is also evidence supported for nausea. So I think sometimes people think about these modalities like they're spa treatments, like it'll just feel so good to get a massage, which is great. It's not bad,
Mm-hmm.
but they are really therapeutic interventions with evidence support in particular conditions, just like medicines are, just like procedures are.
And what got you interested in integrative medicine?
So I got interested in integrative medicine because I was a family doctor and I had all of these patients coming to me that I did not learn how to manage in med school because they would be often women like my age now, but I was younger then. So middle to upper age women who would say, I'm fatigued, I can't sleep, I have headaches, maybe I'm having like palpitations, but I went to the cardiologist and they said it was fine. There must be something wrong with me. It must be my thyroid, I must be anemic, I must have cancer. And so we would do all of these tests and we couldn't find anything. And they would say, yeah, well, I did those tests before and the doctor said nothing was wrong, but I feel terrible. And I didn't know what to do with these people. And so ultimately, I just started trying stuff. And I started trying stuff that I used for my own well-being and just started asking them, like, hey, how are things going at home? How are you feeling about your life? What's important to you? Do you stop drinking caffeine early in the day? Do you move? How do you eat? And when I started dealing with people in that way, in the same way that I was trying to take care of my own well-being, they started getting better. And then
Mm.
they would send their friends, and then their friends would get better. And I didn't even know the word integrated medicine at the time. And I was like, what is this? This must be a thing. And why didn't I learn this in medical school?
Yep.
And then I discovered, oh, this is a thing. This is a field, and it was newer then, but people people are taking care of patients in a whole human way and helping them to get better. And I got really interested because seeing family medicine patients and having medication as my only tool was just anemic. Like there were a lot of people that I wasn't helping.
I think that's the moral injury of medicine is we've extracted a lot of the key things that we need to examine about a person,
Yeah.
about what's going on at home. Dr. Gabor Mate with his Myth of Normal book always
Yep.
talks about how we don't ask those questions about what are you carrying from way back when.
Yeah.
And it for me with a long history of an eating disorder is like a lot of the questions I wasn't asked, they were hyper fixated on very superficial science. I'm like, man, integrative medicine would be huge in most all fields, right? I'm
Yeah.
yeah,
Absolutely, because
I
it
can't
gets
find
it at what's underneath. That's the ideal, right? And
yeah.
if somebody can't sleep, for example, so they're even if they just say they're fatigued, well, why are you fatigued? You could be fatigued because you're getting chemo, you could be fatigued because you're deconditioned, you could be fatigued because of medicines that you're taking, you could be fatigued because you're not sleeping. Well, why aren't you sleeping? So let's talk about your sleep. Are you not sleeping because you have caffeine with dinner? That's a good reason not to sleep. Do you not sleep because your partner snores or there's noise in the room? Do you not sleep because you have all of these cognitive distortions and anxious thinking in your head going, oh my God, what about this? And what about that? And what about this? And what about that? And then your body won't let you sleep. Are you not sleeping because your pain is uncontrolled? Are you not sleeping because you have reflux that's uncontrolled? And so you just, you try to go to sleep and then you just feel a discomfort and you don't know why you woke up. There's a ton of reasons why, but just giving somebody a sleeping pill is like banging them over the head. It doesn't get at what's underneath. And
Mm,
so it works so much better to get at what's underneath. And sometimes what's underneath is you have a history of sexual abuse and it happened in the bed. And so when your body goes to the bed, it feels unsafe. And so then we don't want to just slap a band-aid over that. If that's true and we unearth that, then we need to send you to someone who can help you do work with the trauma. So
yeah.
that I think that whole person approach, sometimes it's all medical. Like sometimes it's reflux and what treats your sleep is a stomach medicine, right? Like I've had that experience before with
Yep.
patients. Nobody could figure out why they couldn't sleep. And then they told me, well, when I lay down, I cough. I'm like, oh, really? Let's try a little of this stomach medicine. And it all went away. Now they can sleep fine. They're not depressed. They're not anxious. They don't have trauma. They just needed their reflux treated. So from my perspective, it's not all non-pharmacologic care because sometimes you need meds. Meds are great when they're great, but you just want the bigger toolbox. You want all the tools. Why just have half the tools?
Yep. And that's why they call it integrative.
That's why.
Nice. And let's dive into this book, Coping Courageously. There's a need for this book. Tell us how this came into be.
Yeah. Well, the first seed, I think, for this book was my own experience. So one of my children had a pretty serious accident, fell off a horse onto her head. And she had a very prolonged recovery with terrible, excruciating headaches that went on for over a year. And then all kinds of associated things. Her, her, she couldn't read anymore. Her swallow was weird and food came out her nose. She couldn't go to school anymore. She couldn't do any of her activities anymore. And her pain was just really disabling. And in the beginning, we went to doctors and they said, okay, brain rest. So she rested her brain for 2 weeks and everybody expected to get all better. And it didn't get all better. And then nobody knew what to do. And the doctors were like, I don't know, more brain rest. Or, well, go to a therapist then. Like those were kind of the two options. Like either it's medical, in which case it should get better, or you should just go to a therapist. And nobody really guided us in how to help this 12-year-old person who's forming her sense of self figure out how to live a life while she was in this excruciating pain, and then how to help her sibling and how the parents could help and how to manage our own well-being and all that stuff. And so it really made me see the ways in which we were suffering. And ultimately we created our own. Thankfully, I'm a physician, my husband's a physician. We created our own treatment plan for her that was integrative. It involved really medical things, injections, medicine, surgery even, but then plenty of complementary modalities like yoga and pain education and guided imagery and meditation and breathing and massage and all kinds of things. It would have been acupuncture, but she refused it. If she hadn't refused, she would have gotten acupuncture. So that integrative treatment plan was what got her better. And I saw that there is a need for people who think this way. And then I started practicing palliative medicine and I saw, oh my gosh, all these families are suffering with this same stuff. And we when we were in it, we didn't really have the understanding about how to deal with acceptance of things that were tough, how to deal with her darkness, the hard part, how to deal with our own sense of inadequacy, and how to deal with acceptance when it clearly was that she was going to be different a little bit now than she was before. Her life would be different. And when I saw it in patients and I learned from my own experience how to help them, I saw that the things that I did to help patient and family A also helped family B, also helped family C. And it started making me realize that there really are insights and tools that we can use to make hard times easier. And I wanted to share that outside of just the amount of patients that I can see in my own lifetime is not that many. And I wanted to share it more widely.
I love that. And I was sharing with you, I think before we started recording, is when I was in medical school and doing rotations with patients that were seriously ill, I would notice that the families would get into discord, like they'd be angry. They wouldn't be talking about the actual illness. They would just be angry and you could palpate it. And sometimes it'd be projected on to the physician or the nurse, whoever was trying to take care of the family. But there was no discussions really about, let's just get real about what's happening. So you had an awesome book launch yesterday. I had the opportunity to be there. And something that really hit home with me was when you said you were observing when things were going well for families and when things weren't going well. And can you share a little bit more about what's in the book, about what things that you were noticing for the people where it was going pretty well?
Absolutely. So what you said is exactly right. There were families who were really fracturing in the face of this serious illness. And there are other families who, of course, were sad and devastated, but were coping well. And I really noticed the difference between the ones who were coping well and the ones who were not coping so well. And the outcome was so powerfully important. The families that were not coping well were separating from each other. So, dad's chemo is not working and the cancer is progressing. And maybe the dad says, looks like maybe it's not working. And the family, this is very common, would say, don't say that. Don't say that. You have to keep a positive attitude. No, 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 dad, don't you dare say that. And so the patient goes underground, right? They had that feeling. They tried to share it with their family, but they got the clear message, we don't talk about that here. And so now all the family members are in their separate corners, not together. Whereas the families that were coping better, they, dad might say that, and the rest of the family might cry and say, oh gosh, well, what are you thinking about that, dad? That makes me so sad, but I hear what you're saying. And I know the doctor did say it's progressing. What are you thinking? Are you scared? What can we do for you? And then everybody hugs, right? And everybody cries together. And then they cry for a while, and then someone says, should I go get lunch? And they go, yeah, why don't we go get lunch? And so they feel it, they have a moment together, but even sadness has waves and it gets better for a while. And then they could go have lunch together. Whereas the families that were not coping so well were like locked up, separate from each other, in trying to keep all the scary feelings away.
Mm.
And I think that showed me, there are subtleties, of course, but it showed me that the central theme really is courage, the courage to look at it, the courage to admit what's happening, to accept this is where we are. It doesn't mean you're accepting, oh, they're definitely going to die, but this is where we are. Like, you have this disease. This is what's happening with the treatment. The doctor said this. The courage to look at the dark parts if someone's feeling really sad or scared. The courage to say the word dying or death if that's what's happening. The courage to be present with somebody who's suffering and not to just turn away
Yeah.
and say, oh, I got to go. I'll go clean up the kitchen downstairs.
Yep.
If someone starts crying, just sit down next to them and hold their hand. So really the central piece was courage to deal with this really hard thing. So that's where the name of the book came from.
It is incredible. So when I was in oral surgery in 2017, I had a serious illness and people didn't know what to say.
Yeah.
And the pain of loneliness when people don't know what to say has left an impact that has shaped why I want to hold space. You talk about holding space, learning how to do that, because what happens is when you're afraid to, you don't know what to say, and you'll share about how, when physicians don't have the cure, we often can leave patients with a sense of abandonment because
Totally.
we don't know what to say, so we don't say anything at all.
Yeah.
And I remember the people who came into my life when they didn't know what to say and they just treated me like a normal person and
Yeah.
tried to listen. And the people who didn't know what to say, and I can't judge them for it because they were scared, but the loneliness that felt. And as we went through COVID and we hear about the loneliness, and a lot of times people facing serious illness were kind of forced to do that alone. And I think one of the greatest gifts you can give your family is having an advance directive and saying, if this, then this, like have an
100%.
explicitly clear, this is what I want, because otherwise you leave the family with guilt if they have to choose for you and you don't know if it's aligning with what that patient wants or not.
And I've seen that so many times and it's heartbreaking. One of the things that I really don't like to hear is, oh my gosh, we don't know what to say. We don't know what to do. Mom's on a ventilator. We never talked about it. Like, we're with our family for many, many years. We have the opportunity to talk about it. But when you don't talk about it, then you could end up in this situation where you have to make decisions for your loved one. They can't make them for themselves. And you have no idea what they would want because you never talked about it. And that's why we have to talk about it. That takes courage too. But the one thing I wanted to respond to what you said that's so important, I think, is even if you don't know what to say, you can say to someone you care about, I don't even know what to say. I don't know what to say at all, but I just want you to know that I care about you and I'm here.
And for the people who are like, oh my gosh, I have not had this conversation. I've tried to approach the conversation with I let the family know where my things are and what I want, but they don't always reciprocate because people have death anxiety. They don't want to talk about it.
Yeah.
And meeting people where they're at can be a challenge if they don't want to talk about it. What kind of advice would you give in situations where a family member wants to talk about it, but other family members are resistant?
Yeah, I think it's a great question. It depends. If it's about an advance directive, which really is a crucial thing for everybody to have, I do think that it's worth trying to push a little bit. So they could read the book, for example. There's a whole section on that it kind of, through a story, explains why it's so important. You could do silly things, like there are people who have advance directive parties. So you throw a party, you have food and cake and music, and you have printed out advance directives for everybody that's there. And you take turns going around saying, okay, tell me one thing on yours. And everybody fills them out and signs each other's for witnesses. And then everybody leaves with an advance directive.
Wow.
So
I never thought about that, but
yeah, so it doesn't have to be so heavy, right? Like, there are all kinds of things that we didn't used to talk about. You couldn't say pregnant, you couldn't say cancer, you couldn't say erection. We didn't talk about periods. And now we talk about those things, right?
Yeah.
They're awkward. It's fun. I don't want to, but you just do. Death
My
is
mom did not
it's
tell me
big,
about periods, actually.
and
It
that's not great, right?
it took 3 years to me to be like, "Yeah, I totally have had a period for 3 years."
Oh,
Thanks,
heartbreaking.
Ma.
Thanks a lot,
She'll
Mom.
listen to this. She listens to most. So hi, Mom. Thanks for not telling me about periods because the expectation with school would, but it like whatever, not really,
Yeah, and probably a generation before that, maybe nobody told little girls.
No.
And imagine that, if that's you didn't even know that was going to happen. So these
Yep.
things that were taboo to talk about, this is just kind of the last one. And I think sometimes people have this weird like dark magic thinking about it, like if we say death, people will die, but that is not how death works. You can say death and people won't die. It's okay. You can talk about the fact that someday every single one of us is going to die. That's just the way this game is played. I don't know why, but that's the rules, and we all know it. So filling out an advance directive is not really news. Like, hey, guess what? Someday you're going to die. So am I. This is just a form about that in the future. It's not even happening now. Like, it's not really even that scary a thing to do if you do it long before you're near the end of your life. It's just a thing you should do. Like, you should have a will, you should have a financial power of attorney, you should have an advance directive. It's just a thing. It doesn't have to have this heaviness about it. So, I would suggest that honest, truly, people read the book. If they have a family member who's struggling, maybe read them that chapter because there's kind of funny parts in it. And part of the idea is that this does not have to be heavy. Like,
Mm.
Dad, I have a really important thing to talk to you about. We have to do your advance directive. It doesn't have to be like that. It can be like, look, we're getting Thai food and we're going to print out these advance directives. I'm going to do mine. You're going to do yours. Everybody should have it. We haven't done it yet. We're just going to do it. And then we're going for ice cream, right? Like it doesn't have to be heavy.
Yeah, I think often because of my own life journey, I've thought about end of life quite a bit. And I was thinking if it is bringing up fear, that's something, I'll speak personally is like you look inward. For me, I often find, ooh, I'm currently missing for me, it's going through like a spiritual crisis. Or I
Mhm.
find that once you accept death is an inevitable outcome of living here on earth, I find you can be more intentional about living. So
Totally.
reframing it in a way that's like, I'm just going to face this, accept this, because my denial allowed me to have more risky behaviors than accepting death is inevitable and
Yeah.
being like, okay, well, I'm not going to spend so much time doing all those things that are sucking out my soul. And I'm being more intentional about what really matters.
Yeah, there's a couple of really important things in what you just said. So the one story that I'll share is that so I was in family medicine first, and then I got sort of by accident ended up in hospice doing as a team medical director. And a lot of my patients in family medicine, as I mentioned before, were kind of not happy. They just like life wasn't great. They didn't feel well. They didn't like their job. They didn't like their spouse. Just they weren't very happy. And then I went to hospice, and a lot of the people were happy, which was the total opposite of what they told me in medical school, which was if you fix people's medical problems, they will be happy. And if they have unfixable medical problems, they will be sad. So, of course, they were sad also. But truly facing your mortality makes you not want to waste today,
Yep.
right? Like if you see your mortality in front of you and you're not in deep denial like many of us are for most of our life, you don't.
I was. I
Me
was.
too. Yeah.
It's taken a while being around people like you. It's helping. It's helping. It's helping. We talk about it more. We just
It's
talk about it
important.
more.
Right. And if you know, like if you believe that that is a truth, which it is for every one of us, why would you spend a whole day with some jerk that you don't like? Right? Like
Mm.
you're not going to waste this day doing something you hate if you don't have to. So what really struck me when I started working with hospice patients is how about I don't wait till I get cancer to learn this lesson? What if I learn it now and
Yep.
actually fix my life so that it is how I want it to be long before I'm faced with my mortality right in front of me, hopefully. So it actually is life affirming to realize that you're going to die one day because it makes you see, like, gosh, I don't want to waste my life then. Like, if I spend a whole day being mad at X person because they didn't invite me to X thing, well, that's just stupid and that's a wasted day. Like, why would I do that? I don't have unlimited days. I
Mhm.
don't want to waste one doing stupid stuff like that. So that's one side. And the other thing that what you said made me think of is when we pretend that we don't know that we're going to die one day, and we try to stuff it down in the basement. The thing is, it doesn't work. We still know. And it takes energy to slam that basement door shut and like put your arms and your knees up against it to keep that awareness out. It takes energy and it's exhausting. So if you really could erase the understanding from your mind, maybe that would be helpful, but you can't. So pretending it's not real takes more energy than going, yeah, it's real. Anyway, let's go to lunch. Like, I don't spend all day
Yeah.
thinking about the fact that I'm going to die. I know it's true. I don't want it to happen, but that's just how it is. But I don't have to spend any energy pretending it's not true.
There's a song that's coming to mind. I started listening to it on repeat recently. It's by Matthew West called What If?
Oh, I don't
And
know it.
he doesn't want to spend the days wondering what if.
I'm writing that
Yeah.
down.
I love Matthew West. And I think it spans, he sings songs that are from a Christian background, but I think it spans just human life.
Absolutely. And I think that's such a powerful image. What if? Because here's the other thing. We have no idea. None of us know. There's a whole chapter in the book about this, that we worry about particular things. And we have no idea if those are actually the things that are going to get us. We just literally don't know, right? It could be a car crash, it could be an illness, it could be the house falls down, it could be a plane flies into your house. Like, you literally don't know. So since it doesn't make sense to worry about every potential thing that could happen, how about we don't really spend a lot of time worrying about any of them, because we literally don't know.
That is one mindset. I will be very transparent that this came up in a therapy conversation last week. Or I think about death too much, and too much for me. I will claim that that's where that definition of too much comes from, because I allow it to get to a place of like, what's the point if we're all gonna die anyway? Like, no, which I'm saying because I know people will
I get
relate
it.
to that. Like, oh my
Yeah,
God,
no,
I
I get
just
it.
spiral, and now I just like, why am I even doing this? Why am I doing things? But okay, and like, take it back. The therapist like, well, and how do you feel when you go into that mindset? Like, I feel awful and depressed, and it
That's
takes
not good.
away, right? And like being more intentional, being like, okay, so there's going to be a better way to reframe that. Is now I'm going to use it to be intentional about my daily living. I'm going to mitigate my risks, but not be paralyzed in my own home because I'm afraid of what's out
Exactly.
there. Because who only knows? You could die of loneliness. It's one of the biggest concerns with our society at this moment.
For sure. And one of the things that I say in the book that I really use for myself a lot is that we should control what we can and let go of the rest. Control what we can and let go of the rest. So I'm certainly not saying, whatever, we're all going to die, like, don't wear your seatbelt. No, wear your seatbelt. Drive the speed limit. Don't drive drunk. Don't text while you're driving. Look at the road, right? Don't do any distracted things. That's what you can control. Does that mean you'll never have a car crash? No, it doesn't. You could do all those things and still have a car crash, but it's what you can control. And here's what you shouldn't do. Spend every moment in the car thinking, what if I crash? What if I crash? What if I crash? What if I crash? Because number one, that's not going to make you less likely to crash, probably make you
Yeah,
more likely to
more
crash.
likely. Yeah, I
Certainly won't
agree.
make you less likely to crash.
Yeah.
But here's what it will do. It will ruin your day. It'll give you a headache and a neck
Mhm.
ache and chest pain and a stomach ache, and you'll have diarrhea and you'll be exhausted. And you did not reduce your chance of a car crash at all. So it's dumb, basically. Like, just don't do
Yeah.
it.
I've done dumb
Control,
things like that before. So I know, I agree.
yeah,
It's dumb. It's
control what you can
dumb.
and then let go of the rest. And so the example that I use, one of the examples I use in the book, is that one of my children has a very serious food allergy to nuts and a bunch of other things. And she has anaphylaxis, so the kind where you can die. And so when I first sent her to school when she was little, when I first sent her, she was like 5, I would worry the whole time she's at school. And so then I'm exhausted by the time she comes home. And does my worrying in my house while she's at school change the likelihood that she's going to die of a food allergy? No, right? It has zero impact. But when she comes home, I'm a basket case, I'm exhausted, and I'm stressed out. So I did no benefit by doing that, and I didn't keep her safer. So
Yeah.
what do I do to keep her safe? Talk to the teacher, talk to the class, show them about EpiPens, teach her how to use an EpiPen, make sure she has it with her all the time, right? There's a lot of stuff I could control. So I should control those things to reduce her risk the best I can, and then let go of the rest. Because if she's at school and I've done everything I can do to control, spending hours worrying has no benefit, only downside, no upside. And so we can choose not to do that. There are techniques in the book, and plenty in the integrative world. There's techniques to manage our own anxiety. But first we have to decide to.
Yeah.
Because I think sometimes we have a little magical thinking about that too. Like, I worry to keep her safe. If I don't worry, she won't be safe. That's not true.
And challenging. Is it true? It's like the whole Byron Katie. Is it true? You absolutely believe it's true, and go down that list. Yep. But I know you have extraordinary content in the book. I got to hear a little bit of it last night. I'd love if we can share that with our audience.
Sure. I'd love it. Thank you very much.
And you can show them. I know we got a poster of the book, but I saw you hold it up there. Book. Very beautiful. I love the design.
Coping Courageously, a heart-centered guide for navigating a loved one's illness without losing yourself. That part's important because it's exhausting to take care of an ill loved one. And the self-care part is often left to the wayside, and it's tremendously important. So I do talk about that in the book, but I think it's important to say here too, that if you are caring for a loved one, you are probably exhausted. You're probably not taking care of yourself well enough. You're probably not getting enough help or asking for help. And that's not the ideal scenario, because you got to put into the tank in order to drive the car, right?
Yeah.
You have to take care of yourself if you're going to take care of somebody else.
And how easy it is for us to conceptualize but not apply, right? The whole oxygen mask on first, and how can you apply that in your life? Absorb, apply.
Right, exactly. And because of that, in caring for families, when people are stressed out, they only have so much brain power or time even to think about their own well-being. So the model that I use of filling up your cup and how to know what to put in it and how to know how to plug the leak so it doesn't leak out so much, what's emptying your cup, that's the model that I use because it's what I found most helpful for families. And it allows people to put the specifics in the way they want to, because not everyone should do yoga. Not everyone wants to do yoga. Not everyone needs to meditate. Not everybody needs to run. But what matters for us is to figure out what empties my cup, and let me do less of that. What fills my cup, let me do a little bit more of that, and start small in terms of, don't try to do 10 new things. Try 1 or 2 new things, and try 1 or 2 things that are emptying your cup to do less of those things. And that way, little by little, people actually can start to fill their cup back up so that they don't feel so depleted.
I love it. It's a great visual.
I draw it out, actually.
Nice. Even better. I'm going to draw it out later as a reminder.
Yeah, you should. And in the book, it's drawn out. It's just the drawing that I use with patients all the time because
awesome. Cool.
I think it helps for us to draw it, to draw the cup and what are the things that fill it and what are the things that empty it. Helps to see it as a visual and then put it up on the wall.
Awesome. I love it.
Okay, can I read a little bit of a chapter?
Yeah.
This is chapter 4. It's called Act in Advance. Thomas was a cheerful man in his late 60s with flyaway white hair and a warm smile that made it seem like we were old friends. When we met, Thomas was propped up in his hospital bed reading a newspaper and chatting with a quieter man who introduced himself as Jeremy. "Hi, Doc," Thomas said brightly. "Jeremy and I are just hanging out. Want to join us?" They had managed to create a lazy Saturday morning vibe, despite the antiseptic smells and vomit basins on the windowsill. I came to meet Thomas that day because his oncologist had requested a palliative care consult. Thomas's prostate cancer had spread, despite hormones, immunotherapy, radiation, and prayer. Despite his jolly demeanor, Thomas understood that things weren't going all that well. "How have you been holding up?" I asked him. I saw a flash of sadness in his eyes before he joked, "Better than the average bear." I validated his vibrant attitude and waited for him to share what was underneath his everything is peachy facade. After a few minutes, his face softened, he looked at Jeremy, and he audibly sighed. He shared that he hated losing his old life and his old self, he told me that he hated the fatigue most of all because he couldn't go for long walks with Jeremy like they had done every weekend for years. And Jeremy is It seemed clear to me that Jeremy held a special place in Thomas's life, and identifying sources of support and potential surrogate decision makers was a part of my job as a palliative care doctor. My roommate, Thomas said firmly. We had a lovely chat about Thomas's work as an architect, magical trips that he and Jeremy had taken over the years, and which nurses understood his sense of humor. All my attempts to move the conversation into deeper, darker territory were met with a firm and smiling redirection. Is there anything that's worrying you? I asked. Not really. Have you been to Greece? We loved Greece, didn't we, Jeremy? He replied. I asked if he had an advance directive or had chosen anyone to make medical decisions for him if he ever couldn't make them for himself. Oh, I know. I should do that. I need to make a will, too, and clean out the attic and organize my pictures. I'll get to it, Doc. I promise, he said. I gave him a blank advance directive and encouraged him to fill it out before he left the hospital. He didn't. I saw Thomas a few months later when his treatment had caused a problem that landed him back in the hospital. His shine was tarnished. His big personality was muted, but it wasn't gone. Hey, Doc, he said. Great to see you again, he said sarcastically with a dramatic eye roll. It's great to see you too, I said. What's new? I guess Jeremy's getting tired of me, so he sent me back to the hospital, Thomas said with a half smile, glancing at Jeremy, who was sitting in a chair by the window, not saying a word. Jeremy looked tired. I could see that Thomas was declining, and I was concerned that he still hadn't identified a medical power of attorney. Thomas wasn't married and didn't have children, so if he lost the ability to make decisions for himself, it would legally be his two siblings who would decide what happened to him. I tried to make my questioning sound conversational, but I had an agenda. What's up with your family? I asked. Do you see them much? My brother is an a-hole, and my sister keeps trying to get me to accept Jesus, so no, I don't see them at all, he told me. Uh-oh. Thomas was a strong and independent man who liked things the way he liked them. He wasn't seeing that if he didn't complete a living will and assign a medical power of attorney, the very end of his life would be utterly out of his control. And the controllers, his a-hole brother and proselytizing sister, might not choose for him what he would choose for himself. I gave the little speech that I'd given hundreds of times. Advance directives are extremely important, and everybody should have one. I have one, my husband has one, even both of my young adult daughters have one. An advance directive has two parts, a living will and a medical power of attorney. The living will part says what you would want in the future if you were near to death or weren't expected to ever wake up again. The medical power of attorney states who you would want to speak for you to the doctors if you couldn't speak for yourself. That person would make medical decisions for you if you ever couldn't make them on your own. Thomas took a deep breath and looked at Jeremy. He didn't say a word. Everyone should have an advance directive, but for Thomas, it was a palliative care emergency that he didn't have one. Although Thomas had never said so, I had a feeling that Jeremy was his person, the person he had spent his life with, sharing adventures and hardships, and the person who should be speaking for him as this chapter of Thomas's life wrapped up. Yet if Thomas didn't act, it wouldn't be Jeremy who would be deciding about breathing tubes and CPR and artificial feeding. It would be two people who shared Thomas's DNA, but not his worldview. I gave Thomas another blank advance directive and nearly begged him to fill it out before he left the hospital. He didn't. If you read the book, you'll hear the rest of the story.
Yeah, I can't wait.
But I will never forget them, because the way that story ended up, he ultimately made the right decision at the last second, and a terrible catastrophe was averted. I just will never forget them. It really illustrates how important it is to make sure that you pick somebody to speak for you if you ever can't speak for yourself.
And ask them. So what happened to me was I created an advance directive, and the person I picked to speak for me couldn't do it. Like, refused, was like, nah, I can't do it. And he was open about it. And I thought it'd be the one person that would just use the mind and not like get all wrapped up, but I was wrong.
Yeah.
And so it's important to have those discussions, because maybe that person doesn't feel that they could take that on without extraordinary guilt.
Yeah.
So sometimes I'm like, well, maybe I'll just assign the doctors will make the decision. I don't know. Like,
You
who
know,
knows?
sometimes it doesn't have to be the person that you think is closest to you. Often it's not the spouse. Sometimes people pick a friend or a cousin. You know, the key really is someone who you feel like would tell the doctors what they think you would want, not what they want, but what you would want. And then the other part of filling out an advance directive is to tell the person who has agreed to be your medical power of attorney what you want. Because the goal, you know, it's just a piece of paper. Like paper is not the be all and end all. Really, what we want to say is, hey, this is who I am, and this is what's important to me. And if I'm coming towards the end of my life, or if I'm in a persistent vegetative state, like a coma where they think I'll never wake up again, this is what I would want now that you know me. And then that puts the person in the position to make the decisions when you're in whatever situation you're in. There's another story in this same chapter, kind of in the other direction, where a person did an advance directive, but they did it in their lawyer's office with no guidance. And they ended up choosing something that really was not what they would have wanted. But by the time it showed up, she couldn't make that decision anymore. And so her care also went in a bad direction because the living will, the advance directive, didn't reflect what she would want. So like me, myself, for example, my kids know this, my husband knows this. I know that at some point I'm going to die. And so if I'm in a state where I'm never going to wake up again, the doctors don't think I'm ever going to wake up again, I don't feel the need to be here on this planet another 2 weeks, say.
Yeah.
If I
Yeah.
know at the end it's going to end up the same, if I can be me, like I know who you are and I can communicate with you, then I would want to be here. But if I'm never going to wake up again or recognize anybody, then I don't need to be here anymore. And that is way more important than like check CPR or not CPR. They get the gist of it, you know? And
Yeah.
so that's why the conversations are important. It's not just sign the form. It's pick a person and then have the conversation with that person. And the form can help you, can kind of help guide the conversation, but really it's the conversation that matters.
I always get nervous in medicine about those timelines of we don't know if that person's going to wake up or not.
No one knows for sure. That's true. But there are times when, with all the medical knowledge that exists on Earth, we have a pretty good idea.
Yeah. And I think
And
that's where you ask the physicians, the collaborative physicians will they'll have multiple who provide that insight and the repeated opinion based off of their evidence and their experience levels.
right. And so it's that combination of the medical reality with the person's goals. So
Mm.
without either of those two things, you can't make a good decision. If you don't know the medical reality, then the goals don't matter because you don't, you know, like my advanced directive says if I'm at the end of life or in a persistent vegetative state, I don't want to be resuscitated. But if I get hit by lightning tomorrow, I want to be resuscitated because the
Yeah.
chance you can bring me back to who I am is pretty good. So I
Mhm.
want to take that risk then. I want to try it. But if I'm bleed into my head, I have a car crash, I bleed into my head and I've been in a persistent vegetative state and the chance that I'm going to wake up is nearly zero, then I don't want to be resuscitated.
Yeah, I share
Yeah, so
that.
it's not about the like CPR, no CPR, it's in the context. And so you kind of have to
Yeah.
know the person and what they care about. Some people really do say, I want to be on earth every single day I can be on earth, no matter what. It doesn't matter if I'm asleep and I never wake up again. Like that, I don't care about that.
Mm.
I want to be on earth every single day possible. That person should be resuscitated. That's not what I want, but everybody's different. And that's why the doctor shouldn't decide for us because they don't know us and what's important
Mm.
to us.
I love how you showcase these educational opportunities in your book through story, where we can really
Yeah,
see ourselves in the situation.
every
So,
chapter starts with a story. Every
yeah,
chapter.
we've
Yeah.
got to tell these people where they can find your book.
On Amazon, I would love for you to take a look at it on Amazon. At the moment, that's where it's available. Soon it will be more widely available, but right now that's the best place to get it. And the other thing that I think is important is that obviously it is appropriate for families who are facing a serious illness, but it's also appropriate for clinicians. because there's a lot in there that helps the clinician figure out what they should say when a patient says, for example, how am I supposed to live now that I know I'm going to die?
Yeah.
Right.
Mm-hmm.
And one of my patients said that to me, and there we discussed it. That's one of the stories in that chapter, because really the stories in this book are through the lens of a physician who's helping people through these things. And I think that physicians and nurses and nurse practitioners and PAs and other kinds of clinicians often don't get training in how to have these tough conversations, but they find themselves caring for these patients. And you were there last night at the launch party.
Yeah.
Several people shared how wounded their families felt when physicians wouldn't have these conversations. And I think we all agreed as a group that it wasn't that the physicians were bad people. They probably were just suffering themselves. They didn't know how to have this conversation. They probably felt guilty that they couldn't save the person. And rather than being present and muddling their way through the conversation with their humanity, they ran away. And that is wounding to patients and families. And so I think clinicians are obligated to figure out how to deal with these things and how to be present for people who are going through serious illness.
I think we need a whole rotation on how to hold space for people. And
Yes. Oh my
I,
gosh.
I mean, of course, palliative care and hospice rotations in order to help people have conversations when they don't have the answer and they don't have a cure. They know a
Yep.
cure doesn't exist for the current situation.
Yep. There's an image that helps me a lot, which is walking beside someone on a difficult hike, let's say.
Yeah.
So we don't have to carry them. We don't have to even carry all their stuff. Say we can't, but we can always walk beside them. So obviously, if we can cure someone, we will try to cure them. But there may come a time when we can't cure them, but we can always walk beside them. And that is of huge value. And that's what I think a lot of clinicians don't realize is what a huge value that is. They think it's no value. Like if I can't cure you, you don't want to see me anyway. And so I'm just going to hide from you and la la la, never mind. I don't have to think about it anymore. But that wounds the family. Whereas if the clinician would just still be present and say, I wish I had something that would fix this. I don't, but I wish I did. And I'll be here with you in whatever way I can be of support to you. That
There
means the
is,
world to people, you know?
yeah. So the physician who changed the trajectory when I was in oral surgery, and I was like, yeah, I was the person. I was like, no, I want to do exactly what this person is doing. He was family medicine, and I'm not going into family medicine, but I want the similar role that he had. I'm applying to psychiatry. And the reason is because when I was with him, he at one of his roles was to consult with patients that had stage 4 cancer. He would go into the consult room, he would sit down, he says, what questions do you have for me? How can
Yeah,
I best serve you? How
love
can I
it.
best support you? And the theme of those conversations was that the patient usually came with questions about if they can take supplements with their chemotherapy, or the theme was that they wanted something that they could control
Mhm.
no matter what. And he
Yep.
had curious, non-judgmental, going through the evidence, like, yes, you can, no, this is why not. But his main goal was to hold space
Yeah.
and to walk alongside, as you just showcased. I'm like, that. And when I was in oral surgery, all the patients were asleep and I couldn't do that. And I was like,
Mm.
so it showed me and his that rotation, consulting with him, meeting you, y'all, you have very similar values and approach and philosophies that I really respect and appreciate, is bringing the humans back into healing. We'll say that again.
Yep.
Like, yeah, I gotta do that. I gotta figure out a way to do that. So I was looking into doing palliative care psychiatry.
Nice.
Yeah.
Fantastic. Oh gosh, that's amazing.
It's been 7 years in the making, but finally applying. But you know, my
Yeah.
journey a little bit is I got closer and closer every step of the way. But
Mhm.
enough about me. We're here for you, this amazing book, and you do much more. You've got so many different ways that people can tune into your podcast. They can find you for courses, they can find you for coaching, they can find you for educational content. Let's
Mhm.
hear all the things and all the ways that people connect with you.
Yes, absolutely. So families, in addition to reading the book, can actually have a deeper dive course if they want, because it occurred to me that I think some people will read the book and say, oh, yes, this is us. My family is struggling in this way. We need more tools. So There's a video course in development that will be done very soon that will take people one level deeper if they're interested. And then I do take some one-on-one consulting clients as a family, helping them figure out a plan to get through this experience. So not as their doctor, but more as their coach. And from the physician and clinician side, it's really important to me to spread the word about this idea of integrative palliative care so that palliative care is not just all medicines, but just has a bigger toolbox to include the complementary modalities. So I have, of course, as you know, teaching physicians and other clinicians how to manage people's physical, emotional, and spiritual suffering using both medicines, but also other complementary tools in an evidence-supported way. So people say sometimes things like, well, does acupuncture work? Which I think is as silly a question as, do medicines work? Because the answer, of course, is it depends, right? Like if you have cancer and you take a reflux medicine, it's not going to help you. But if you have cancer and you take chemotherapy, it will help you. So what we're looking for is evidence-supported modalities, and what if they're helpful for anything, and if so, what? So acupuncture, for example, has great evidence for nausea, vomiting, depression, pain, sleep, anxiety. So those are the places that I would particularly want people to know that if they have a patient with these things, they should consider acupuncture in their toolbox, not just medications, for example. And then the whole mind-body connection is so important and so helpful. And there's all kinds of modalities that we can teach patients about. But one of the greatest things about this integrative approach is that all of that stuff also works for us as physicians and clinicians. And you can't really do whole person care if you yourself are super depleted. And so you're obligated really to care for yourself first, to fill up our own cups first, so that we have this empathy to share with other people. And so when I've taught this content to medical students for more than a decade. And I always ask them to have two channels in their head at one time. When you're learning this stuff, learn it for your patients, but then also learn it for yourself. And so that combination of using things for me, now I really get it. So now I'm a great educator for you, patient, to tell you why this really works and how to put it into your life, because I've done it myself. That just creates these really incredibly effective whole human doctors. And so I want there to be more of us like that. Like you are one of those too. I want there to be more.
Well, it's the whole live it to give it. That's what we say in coaching often.
That's exactly it. Yep.
And where should they go to find you?
So they can go to, from the patient perspective, copingcourageously.com, copingcourageously.com. And the more physician and clinician focused stuff is at integrativepalliative.com. But the secret truth is it's the same website. So either way, we'll get them ultimately to the same place.
Awesome. I love it. And we'll make sure to have that in the
Thank
description box below. So any last takeaways you want to share with the audience today?
Yeah. Take care of yourself in an active way, because whether you're a clinician taking care of patients or you're a human being facing some kind of either aging parent or illness in the family, the biggest mistake that everybody makes is they're hanging on by their fingernails and they say, no, I'm okay. I got it. I'm still okay. And we should be filling up our own cup 1,000 years before we think we need to. So wherever you are right now, do less of what makes you unhappy, and on purpose do more of the things that bring joy to your life and well-being and fill you up and make you sparkle. Do more of those things, because it makes all the hard stuff in life just a little less hard.
Well, I am certainly going to set the intention, invite other people to set the intention right after they're done listening to us, and go really spend some time to observe and identify what those are. Because it's easy to hear it, but then we have to apply. And for me, I have to be very intentional and be like, okay, what is draining my cup a little bit? What does fill my cup? And how and when am I going to let some of that go and increase some of the things that are filling my cup? So,
well, let's pick one thing right now. I will try to get more sleep. I'm not so good. I stay up too late and then my dog wakes me up in the morning. I'm going to try to go to bed earlier. How about you?
I'm going to spend more time reading things that are not work related.
Look how easy that is. Perfect.
Yes.
Great.
Yep. Which I think reduces. When you choose yes to something, you're saying no to things. So you have to remember to say no to the things that you want to let go from your cup.
Yep.
Because sometimes what goes when we are caregivers are the things that would have filled our cup, but we don't give ourselves permission to prioritize those.
100%. And I think the model we have to think about is a gas tank. You know, if you're late for that meeting, but you didn't put into that gas tank and it runs out, you know, you said, oh, I can't stop for gas because I'm going to be late. You know what made you really, really late? When your gas tank ran out. So all the things that are so important to us of caring for patients or caring for our loved one, if we get so depleted that we get sick or we just can't do it anymore, or we get so burnt out that we're not good at it anymore, then we lose our gift. And so it really helps the other person if we fill ourselves up. It's not selfish. It's part of helping the other person.
And since we talked about a little bit of observing life from this perspective that we all die, I'll bring up on my channel, I have Bronnie Ware's, she has the 5 regrets from dying, the top 5 regrets from patients who are dying.
Yeah.
And the regret that really stuck out was living your life for others and doing what others expect you to do and not living for what you truly want. So you showcase how important it is to make sure we're grounded on what do we really want for our life.
Yeah.
And I'll leave that for people to explore.
Love it.
But thank you so much, Delia, for being with me today, for sharing your book, for sharing your insights, and most importantly, yourself.
Thank you so much for having me.